Thank you, Jason. Good morning, everybody. Congratulations to NAR for hosting this important meeting. There are not a lot of us here, but I think that our reach might be a little greater with the sharing of the materials and the information. I want to congratulate Les on his appointment. I think we're really well served as a youth health sector by someone with Les's breadth and his long-standing advocacy for children, his understanding of systems and how policies work in government and that sort of thing. And it gives me enormous pleasure. I'm actually speaking on behalf of CAR, so Fiona and I have authored this presentation. Fiona has an inspiring ability to read enormous documents and see what's missing and then draft a response, which we then workshop a little bit together and with other staff. So today is also talking about our response to the documents and the issues that have been discussed. Just the outline for the talk, and by the way, the cartoon doesn't translate into all cultural environments, but it raises for me the interesting question of why adolescents don't fit. You know, was it a joke to create this age group? Because there's either a benign neglect or a crisis mentality. No one's quite comfortable, and our job is really to find where young people fit in a system that's constantly trying not to acknowledge their needs. I want to talk very briefly about why we care about this age group so much, and then the fuel for advocacy is really an evidence base that's building, and how do we create that and then make sure that it impacts on policy and practice. And then the timeliness of the youth health policy, I'm going to mention how that came about and why we're so pleased that it's actually getting up and being made public. This slide has enormous personal relevance to me because it was drawn. It's a digitalised drawing that's been coloured by a young woman who was suicidal and spent many, many months at Cell Block. The original Cell Block was created, as you know, as an initiative of the Children's Hospital at Camperdown in 1990. And she's basically saying that whatever the adversity that faces you and has in the past, let's have hope, let's be optimistic and see the possibility of good outcomes. Peter Drucker, the wonderful commentator on all matters corporate, says that strategic planning does not deal with future decisions, but with the future of current decisions. Why we should be hopeful as a sector is because we can now have an input. And I think, with people like Les present and also batting for us in the system, we can be hopeful of being heard at least. Young people are important quantitatively and qualitatively, and we all know that they make up almost 20% of the population. If you're an Indigenous young person, you and your peers make up something like 50% of Aboriginal communities. So really important in terms of just how many there are. And the issues that we know and live and breathe are that there is much suffering and cost, personal, financial, social, in terms of the issues young people grapple with. Most of these are psychosocial and preventable and don't always get the attention they need. Sometimes they're invisible. And the leading causes of adult morbidity and mortality start in adolescence. So the continuity argument, as devastatingly obvious as it is to us, we're constantly having to reiterate it. The World Health Organization, which established its program on young people in about 1990, as well as the same time Cell Block became an entity, have been putting out for decades the notion that young people are developing, they need information and skills. This is really the resilience building issue. Safe and supportive environments, access to people who care about them, and this notion of youth friendliness, which has become a little passé in our use of language, but how true it is if young people don't feel that the place cares about them as people, they're not likely to go there or to trust the healthcare providers. Now, we've read all these documents, and it was very nice from Solange and Les to get a reiteration of the main points and the main concerns. We know that young youth health services exist, so Medicare Locals in particular, with its focus on primary health care, is going to have to come to grips with how those services get linked in and supported. And I just make the point, an historical point. Cell Block was established by a hospital and supported by a Department of Adolescent Medicine for many years until the hospital moved, and that was a very strong connection between primary, secondary and tertiary healthcare, and there have been other models for that in other places. The philosophy of Medicare Locals does fit well with our understanding of what a good youth health care system is. Access, coordination and integration across levels. I was very interested in Solange's remark on behalf of NCOS that this is not a strength of the current restructuring plans. So we have to then see how we as a sector can make sure that this happens for our age group. The mention of inequalities and inequities is so important to us as a field that's concerned with marginalised youth, and we should be incredibly concerned about how much Aboriginal young people miss out in terms of good health care and education and all the other things that make you a successful person. So once again, at the pen of Fiona Robards et al., we have said, please be careful to look at inequity in resource distribution. Fiona's mapped services for young people throughout the state. It is clear that the metropolitan areas win and rural and remote areas lose out. Now, the centre, as you know, was an initiative arising out of the previous youth health policy. It was set up at the Children's Hospital where the strongest adolescent health and medicine services existed. And the view was to create a statewide capacity building technical resource type of service that would look at how to be organised, how to be multi-sectoral and how to focus on better health outcomes. That's why the centre was established. The basic tenets of our centre build on similar centres. The Centre for Health Promotion, the National Centre for Health Promotion, for example, does exactly the same things. Builds resources to help people practice public health, education training, research agenda, advocacy and policy development. They're the things we're doing. And the notion of networking and partnership building is the modus operandi of our centre. The more people who feel this is their centre and have a stake in what we do, the more powerful a voice we will have. The Access study has given us our evidence base for better practice. We chose the word better practice because good practice didn't seem enough and best practice seemed arrogant. We had a big debate about that at the time. But these were well-funded studies that looked at the obstacles to care, to primary health care, and the solutions. Massive investment. The government gave 2 grants of around $130,000 in sequence, and out of that came a pretty good understanding of how things work and how they could work better. And these documents are still available and downloadable. Phase 1, Phase 2 gave us the evidence base. There are little projects happening that are about strengthening evidence for positive outcomes. And one example, if we were ever funded properly to do it, would be to look at GPs working in youth services. It's a really neat idea. It's not been evaluated. So once again, that would be a more drilled down sort of project. But even now, we can say that we're influencing systemic change. So we're at Phase 4. And the reason I say that is because the framework is now well established. It's been utilised, modified, but given respect and recognition for its evidence base. And we're very, very pleased about that. This series of research projects had led us to understand the diversity of services for young people. In other words, there will never be a single model that suits everybody. And now we have some complexity in New South Wales because we have Headspace, not only here, but growing here and coming. There'll be more Headspace services next year and beyond. We have the mental health service model, which is drawn on the youth health model, and then we have other services that are less well funded, more vulnerable, but certainly mental health is driving through and contributing. Identify standards for organisational performance around youth health, what we call the 7 principles of better practice, come from the Access studies. We did discover that evaluation and evidence exchange was not undertaken well throughout our sector, and that staff really crying out for professional development and support, which is not always easily accessible. It's become one of our obsessions in our centre to make sure that general practice is mindful of what young people need and links up with youth health services wherever possible. These are the principles of better practice. I constantly quote Groucho Marx, who said entertainingly, these are our principles. These are my principles. If you don't like them, I have others. But in actual fact, these are the 7 that were chosen by this process of stakeholder, expert involvement, plus what the research was saying. And this is what it looks like. This is actually an example of a self-evaluation on youth participation, but also on those other areas. A service could really go through a process of looking how well they're doing things and use that as a basis for improvement.